The next examiner is Dr. Anupama Gil Sharma. She is Associate Professor in Atal Bihari Vajpayee Institute of Medical Sciences and Dr. RML Hospital. The area of interest are critical care, difficult airway management, regional blocks, and transplant anesthesia. The PG who will be in the part of discussion is Shivani, and we'll proceed with the session.
Dr. Shivani, can you pick up the drug? I'll be showing you the drug. Can you tell us something about the drug?
एक पिकअप के लिए रखा था, I think वो लेंगे.
Which drug is this? Tell us something about this drug.
और एक पार्सल भी
The drug shown in the image is an ampule of morphine. It contains 15 mg per cc. It is a naturally occurring opioid.
Very good. So, can you classify opioids and how are they classified?
Ma'am, opioids are classified on the basis of their occurrence into natural, semi-synthetic, and synthetic. In natural, we have morphine, piperacillin, thebaine. In semi-synthetic, we have oxycodone, hydrocodone. In synthetic, we have phenylpiperidine derivatives like fentanyl, remifentanil, sufentanil, and pethidine.
Very good. Have you heard of the opioid receptors? How do you classify opioid receptors? Give just a few examples.
Ma'am, opioid receptors are mu, kappa, and delta. The drugs acting on mu receptors are morphine, fentanyl, alfentanil, sufentanil.
So how do the opioids act? What is the duration of action, the onset of action taking morphine as an opioid, and how are they metabolized?
Ma'am, the onset of action of morphine is 1 to 2 minutes. It peaks in 30 minutes and the duration is 1 to 2 hours. It is metabolized in the liver and it is excreted unchanged 10% in the kidneys.
And what all preparations does morphine come with? And is there any other route apart from IV that we can give it?
Ma'am, it also comes in oral preparations in 15 mg, 30 mg, and 60 mg tablets. These are given for acute and chronic pain. It's also given in palliative care for cancer chemotherapy patients.
Very good. So morphine has its role in WHO step ladder for pain. So no, it's a very potent opioid. Okay, so what are the side effects of opioids? It's important side effects, and how does an opioid overdose present?
Ma'am, the main and most important side effect of opioid overdose is respiratory depression. It represses the respiratory rate. On cardiovascular system, it causes bradycardia and hypotension. It also causes pinpoint pupils. And we treat this by giving opioid antagonist naloxone.
So it can cause nausea, vomiting, pruritus. Respiratory depression is the one which is most important. So one has to monitor the patient in the perioperative period. And opioid overdose is reversed with naloxone typically. And if the opioid overdose is with buprenorphine, then the drug of choice is doxapram, because buprenorphine is more at kappa receptors, more affinity at kappa receptors, and naloxone is an antagonist at mu receptors. Very good. So with this, now we move on to our next drug. That is Dr. Neeja ma'am will be asking this drug.
Okay, can we see the ampule? Okay, while she's sharing it, could you tell me who discovered morphine, Dr. Shivani?
Ma'am, morphine was discovered by Frederick Turner, and it's named after the Greek goddess Morpheus, which is the goddess of dreams.
And it is which kind of drug? There is one more classification. One was based on structure, another was based on the receptors on which it acts. So which type of compound is it?
Ma'am, it's a hydrophilic compound. We divide it into lipophilic and hydrophilic based on the plasma solubility. If it is soluble in plasma, it is lipophilic, and the duration of action of which is shorter and onset is also quicker. Morphine is a hydrophilic compound, so it crosses the blood-brain barrier slowly, because of which the onset is delayed and the duration is prolonged.
Excellent. So I am showing you here a picture of a lipophilic drug. Describe this drug for me.
Ma'am, the drug in the given image is fentanyl citrate. The Formulation available in our hospital is in 2 ml and 10 ml ampules, of 50 microgram per cc. The dose of this is 1 to 2 microgram per kg.
So, routinely using this drug in anesthesia. Okay. And can it be used in infusion form also?
Yes, ma'am.
Okay. And if it is used in prolonged infusion, does the respiratory depression, one of the side effects of it, gets?
Yes, ma'am. It causes wooden chest syndrome when it's given in high doses.
So this is one of the side effects of this drug, which is different from that of other drugs. This is an unusual side effect which is seen in case of fentanyl.
Ma'am, it can also be given IM. It's available as transdermal patches, and sublingual formulations are available as well.
So these transdermal patches are very useful for postoperative analgesia, for chronic pain also it is used, right? Excellent. So this was a synthetic compound that you talked about. Name some other synthetic compound opioids.
Ma'am, we have remifentanil, alfentanil, sufentanil, pethidine.
Okay, so special about remifentanil, how is it different from fentanyl?
Ma'am, remifentanil comes in a powder form. It needs to be reconstituted with 3 ml of distilled water. It's in white to off-white colored powder. The difference, it is different from fentanyl. It is ultra short acting because it is metabolized by plasma esterase.
Right. So here on the screen we can see that this is how it is dispensed. Fentanyl, and it is ultra short acting by virtue of being metabolized by tissue esterases, right? What else does it do because of metabolism by tissue esterases? What are the other advantages of this?
Ma'am, it has precise and rapid titrable effect, and because of which there is rapid recovery after discontinuation of the drug.
Right, perfect. So this is a very, very big advantage. And how are we making use of this in which kind of surgeries?
Because of this, we can use it in daycare surgeries as well as TIVA.
Right. Remifentanil has got a very, very important place in these two specific type of surgeries that we are using. Then, do you think we can give it through neuraxial route, that is epidural or spinal?
No, ma'am, it cannot be given neuraxially because it causes motor weakness.
Very good. So
Ma'am, pethidine was the first synthetic opioid that was synthesized. It is an agonist at the mu receptor.
Have you used it?
No, ma'am, I haven't.
Okay. So how is it? Where? Ampule? 50. Okay, it is. Okay.
Ma'am, it's different because it has an antimuscarinic property, because of which it also causes tachycardia, dryness of mouth, and pinpoint pupils. Additionally, with the other side effects of opioids.
So the
Ma'am, the active metabolites are normepiridine, and in cases of liver disorders, if it accumulates, it causes neurotoxicity, ma'am, which causes altered sensorium and.
yes, this much it takes.
It can cause serotonin syndrome.
You are doing PAC of the patients who are taking MAO inhibitors. Please remember that you do not give pethidine. However, it's hardly used nowadays. And then there's one very important advantage of pethidine. Can you tell me one important usage of pethidine over other opioids?
It's used in post-op shivering.
Excellent. Right.
So, Dr. Shivani, can you do you know of tramadol? Have you heard of tramadol, and how does it differ from other opioids?
Yes, ma'am. I have used tramadol. It's a synthetic opioid. It differs from other opioids in the way it acts. It has an opioid action as well as a non-opioid action. The opioid action is it's a weak agonist at the mu receptor, and the non-opioid action is it inhibits the non-neuronal uptake of serotonin.
Right. So, what routes can we use it, and how does it come?
It's available in 2 ml ampules, which contains 50 mg per cc of tramadol.
What one should be careful with when we are giving tramadol to the patient? What is the side effect which we are scared of?
It causes nausea, vomiting. So to prevent this, we give this.
And the other route which we can give tramadol is also epidurally. 2 milligram per kg is the dose. And one should be careful when giving to a patient who's having epilepsy, because it decreases the threshold potential for seizures, and it can also be used for
seizure threshold.
Have you heard of other opioids like buprenorphine? How does buprenorphine differ from morphine in terms of how does it act on the opioid receptor?
Ma'am, buprenorphine is also a lipophilic semisynthetic opioid. It's an agonist at the kappa receptor.
Okay, so where all buprenorphine is used?
Ma'am, it's used for pain relief. It can be given epidurally, and it's also given for opioid withdrawal.
Yes, very good. So it is given epidurally in a dose of 4 to 8 mics per kg. So it is also very useful in treating the patients with opioid withdrawal. Okay, and how does the overdose of buprenorphine treated as compared to the other opioids?
In cases of other opioid overdose, we give naloxone. In buprenorphine, we give doxapram.
So it has been FDA approved for acute pain, chronic pain, opioid dependence, and it is treated with overdoses treated with doxapram. So with this, now we move on to the next. Dr. Shivani, so what are the pure antagonists, mu antagonist, opioid antagonist you know of?
We have naloxone, naltrexone, and nalmefene.
So how is naloxone used in an opioid overdose, and what dose and how frequently it should be repeated?
Ma'am, it's available. Naloxone comes in oral formulation. It's present in 0.2, 0.4, and 0.4 mg ampules, given in the dose of 0.4 mg bolus, and it should be repeated every 2 to 3 minutes. And infusion should also be started simultaneously.
So it is not by oral, it is by IV. I think that was a slip of tongue. So 0.2 to 0.3 to 0.4 every 2 to 3 minutes has to be repeated. A maximum dose of 10 milligrams has to be given. Okay, and it has found its role now in ACLS. Another algorithm for opioid overdose has been added, in which naloxone has been included.
So, Dr. Shivani, you're drugs. So let's see whether you can tell me something about the other routes through which it can be given, say neuraxial route. Tell me about spinal epidural route through which the drugs are given.
Yes, ma'am. Opioids can be given neuraxially in subarachnoid space and epidural space for intra-op as well as post-op analgesia. The drugs that we commonly use are fentanyl, morphine.
So where does it act? How is the mechanism of action? Can you describe?
Ma'am, it depends again on the if it's hydrophilic or lipophilic. Morphine, as it's a hydrophilic drug, it crosses the blood-brain barrier slowly, and it has high CSF solubility, because of which it has a supraspinal action. Fentanyl, on the other hand, it has a spinal action. It acts on the substantia gelatinosa of the dorsolateral horn of the spinal cord.
Very good, excellent.
Yes, ma'am. Because its morphine is hydrophilic, it has a delayed onset of action, and it is also prolonged. because of which it can also have a delayed respiratory depression. Fentanyl, on the other hand, it has a shorter and faster duration of action.
Duration of action of
Yes, ma'am. Pruritus is a side effect of opioids when given Uraxili, for which we give nal.
इसको मेन स्क्रीन बड़ा तो कर थोड़ा सा शक्ल दिख कभी तो This was like a demonstration that we had given you regarding the questions which can be asked on a topic of opioids. Some of the questions, we're sorry, there was some technical fault because of which a lot of questions you could not hear. So other than that, as a backup, we'll be giving you the PPT also for the questions which can be asked on this topic. There's a very small thing that I would like to tell you. Whenever there is a drug viva or any viva for that matter, always remember to learn the exceptions of that particular situation, or say for that matter about a drug, like she talked about pethidine. So pethidine is unique compared to other drugs, compared to those of opioids, because it has got antimuscarinic effect. So anybody, if suppose asks you, so tell me which is the most different, which is one drug which has got different actions compared to the other drugs, and what are those different actions. So these kind of things you should always remember, because an examiner asks that. Anything unique, anything specific, anything out of ordinary, that is something which will definitely be asked. Rest of the things, yes, you are supposed to know about these drugs because these are used day in, day out. And whenever you are asked about something, like you'll just pick up an ampule. So don't get flustered if you have never seen that ampule. The simplest thing is to read what is written on that and speak about it. And gradually, as the questions follow, you will be able to give the answers, right? Same thing holds true for any equipment also. Like it was told to you regarding your endotracheal tube, just pick it up, start reading from the patient end to the machine end. And that's how you'll be able to answer the questions. So whenever there's anything that is asked, don't get flustered, start reading from there, and then gradually you are able to answer. And if there is something that you have never seen, you have not read, you can always say, I don't know, so that the examiner is able to pass the question to some other topic which you're able to answer better. So now I'll be sharing with you the PPT, where we have, the PPT has been made question answer based. So just read these question answers later on also. They'll be helpful for you to be able to answer on this topic.
Okay. Can't be answered. This. Okay, so these are the things that we'll be discussing. Each individual drug would be discussed, and as the Viva was in your Viva, you have seen that we have discussed Neuraxil opioids also. So whenever opioids are discussed, Neuraxil opioids can be asked, and you get a short note also on Neuraxil opioids. So remember to read that. And fentanyl is one drug which we are using day in, day out. So the drug that you are using on routine basis, please remember to know it in detail. And morphine is a prototype of all the opioid drugs. So please read in detail about morphine. And naloxone is a specific antagonist of all the opioids. So that is another one you'll have to read in detail. Rest of the things, of course, tramadol you're using, those are other opioids that you need to know about. So the question which can be asked is, what is an opioid? So any drug which is, just give me a moment. Ye nikal do main. Any drug which is acting on opioid receptors, and the actions which are similar to that of endogenous opioids. So that you should, so the next question when you answer this, the next question which will be asked is, okay, what do you understand by opioid receptors and what are the various types of opioid receptors? So generally one statement follows the next question whenever these questions are asked. And there is another specific term which is known as opiate. Opiate is different from that of opioids. Opiate is specifically substances which are extracted from opium, and morphine was the first one. From poppy seeds it was extracted. It is a natural drug, so that is why it is called opiate. Later on we had synthetic and semi-synthetic opioids. Endogenous opioids is another term which will you will hear, or someone can ask you as to, do you know what is endogenous opioids? So enkephalins, endorphins, dynorphins, they are the ones which are endogenous opioids, and they also act on mu, kappa, and delta receptors. And our opioids also act on all these receptors only, right? So the next question which can be asked is, how do you classify opioids? The classification of opioids can be on the basis of their structure, on the basis of how they are, whether it is natural, semi-synthetic, or synthetic. So whenever you, even if you do not remember a battery of, all the names, you should at least know the name of one drug. Say like for natural, you have to know morphine, because morphine is the prototype. As far as semi-synthetic is concerned, heroin or say codeine, this is the one which is quite commonly used. And the rest of the other drugs that we are using in day-to-day are all synthetic. That is fentanyl, remifentanil, tramadol, pentazocine, buprenorphine, they're all synthetic opioids. Another classification is on the basis of the receptors. As I told you, there are 3 types of receptors. So, and all these drugs have specific activity on different receptors. So like for pure agonists, morphine, fentanyl, alfentanil, remifentanil, and tramadols, they are the ones which act on mu, agonist, antagonist, and only antagonist are also there, right? Then there are, how is it that they act? So as the action is on the receptors, so by the virtue of acting on these receptors, their effect is seen, which is supraspinal and spinal, and their main effect is by causing sedation and your analgesia. That is the main thing that they cause. Other than that, they also cause euphoria and decrease in ICP. As far as CVS is concerned, bradycardia is the most important thing that they cause. Example, pethidine, which has been mentioned, exception is a pethidine, because pethidine does not cause bradycardia. Pethidine causes tachycardia because of the fact that it has got antimuscarinic kind of an effect, right? Then This is something which was discussed by Dr. Shivani, that pethidine has got antimuscarinic effect. Because of that antimuscarinic effect, it does not cause meiosis, it causes mydriasis. It does not cause bradycardia, it causes tachycardia. And respiratory depression is one thing that whenever opioids come into mind, you always know that it causes respiratory depression, and it acts at medullary center. Because of that, it causes depression, and it causes decrease of respiratory rate than that of your decrease in tidal volume, and eventually in very high doses, it causes complete respiratory arrest also. As far as GIT is concerned, nausea and vomiting is a very, very important side effect of all your opioids. And as far as tramadol, you remember, you are using it routinely. You always give antiemetic with it. Urinary retention, a very irritating side effect, is very common, and it happens also with all the opioids. Pruritus is seen pretty frequently, and it is the itching is more around nose and face, and this is not related to histamine release. Okay. As far as pharmacodynamics and pharmacokinetics is concerned, there are two types of molecules, hydrophilic and lipophilic. Lipophilic are the ones, fentanyl, remifentanil. They have got because by virtue of being lipophilic in nature, they have got faster onset and shorter duration of action. And all of them are metabolized by liver, other than remifentanil. This is another exception you should always remember, that remifentanil is metabolized by tissue and esterases. So because of this, it is metabolized very rapidly. So because of this, all the unique properties that it possesses is by virtue of this property. There's one thing I want to talk about metabolism, that although all of these drugs are metabolized by liver, but even in hepatic involvement, you can give it until unless it's fulminant liver failure. Like morphine undergoes glucuronidization, so it forms 3 and 6 glucuronide. So this is one function which is preserved to very late stage. So you can give it in this situation, and then finally this whatever is formed, this is then excreted in kidneys. So some amount of renal excretion is affected whenever renal failure is there. So then that is the time when their effect can be prolonged. And yes, remifentanil is safest. If you have available, then you can always give it. Okay. This is the picture of Sir Turner. He was the one who had discovered morphine. It was extracted from opium poppy in 1804. You must be seeing lots of historical films and historical programs. There, giving poppy to for relieving pain is being used since 19th century, as early as that. And the name was given from the name of Greek goddess Morpheus. She's the god of dreams, because it causes that hallucination property, causes a lot of sleep. So because of that, the name morphine was given to it. And rest of it is a prototype on the basis of which rest other drugs are also given. You should know about morphine. This is important, that orally also it is available, and it is extremely useful. Oral preparation is extremely useful in palliative care, right? So you will find that the patients of cancer pain, they are prescribed oral morphine. And these are the various doses in which it can be given depending upon what is the effect that you want for this drug. But what we are commonly using it as for premedicant, for analgesic. And morphine, this is a WHO step ladder. Someone can ask you whenever they ask about morphine as to on which step of WHO step ladder morphine comes. So it is initially you start with NSAIDs and paracetamols, and then gradually, then a weaker opioid like tramadol and codeine, and then followed by a strong one, where prototype like morphine and fentanyl. Okay. That was about morphine. This is about fentanyl. So if fentanyl, you are using it very, very frequently, remember that it is 100 times more potent than that of morphine. In exam, if you cannot remember which is more potent than the other one, please remember any drug which has got the mg, suppose, are more anyone which has got lesser dosage, that is more potent than the other one. Like fentanyl has got much lesser dosage than that of morphine. It is 100 times more potent than that of morphine. That's how you find out about potency for any drug in every drug. That's a dictum. It has got only dosages 1 to 2 microgram per kg, and it is dispensed in as micrograms only because of the fact that it is highly potent. You don't need to dispense it at much higher percentage. And there is another very simple rule that all the drugs, these IV drugs, they are dispensed as 1 ml is dispensed as maximum dosage of this drug that can be given through IV route. So this is 1 to 2 microgram per kg. So for a 50 kg man, maximum dose would be 100 micrograms. So 1 ml contains 50. So 1 ml on the lower side, they are giving 50 microgram. That is how it is dispensed. These are some very basic and simple rules of IV drugs which are followed. These are the side effects that we have already talked about. This is how your remifentanil is dispensed. We have all talked to you in detail about remifentanil. It is dispensed in powdered form. Okay. Potency, side effects, they are all similar to that of fentanyl. Tissue and plasma esterases, they are responsible for its metabolism. Neuraxial opioids, we have already talked about. You should know where is it present, where does it act. So substantia gelatinosa acts on mu receptors present in substantia gelatinosa, layer of dorsolateral root of spinal cord. Okay. Lot of times in your last 10 years paper, neuraxial opioids question has been asked. So please read it. These are the various dosages. Always remember that intrathecal dosage of all the neuraxial opioids is much lower than that of epidural dosage. So intrathecal of fentanyl is 10 to 25 microgram and epidural is 50 to 100 microgram bolus, and then we give the infusion of this drug. For morphine also, intrathecal is much lower than that of epidural. The dreaded complication of morphine with through epidural route is delayed respiratory depression, because this is a lipophilic. This is not a lipophilic drug. It is a hydrophilic drug. So that is how its duration of action and its side effect is different from that of fentanyl. The duration of action of fentanyl is only up to 6 hours, whereas that of morphine can last up to 24 hours, and the delayed respiratory depression can also last up to, can be seen even up to 24 hours. And this effect is primarily because of the supraspinal effect of morphine. So there is something very interesting, because morphine has got primarily supraspinal effect. Even if you give morphine through lumbar route in a thoracic surgery, you get it is as effective as that of giving through lumbar route, because it's the neuraxial effect is through supraspinal route. So these are very important side effects that you should know of. And the side effects, how to take care of those side effects. Respiratory depression, the drug to be given for that is naloxone. Please remember that. Even in labor analgesia, these drugs are used, because smaller dosages of local anesthetics can be given, and with the addition of this, the duration is much longer when you give fentanyl with it, and walking epidurals are given because of that. This is how pethidine is dispensed. This is dispensed in 2 ml of ampoules, 50 mg per ml. This is something which you could not hear in the video that we shared with you. And a very interesting drug, very useful for decreasing post-operative shivering, not available. So we are giving tramadol. Even ondansetron also helps it. So this used to be extremely common in days when post-operative shivering was very common, when we were using halothane. In fact, there was a term known as halothane shakes. So that was the time this was very useful. We have used it in our days. That's how I can sort of go on and talk about it. So, well, this is, remember that meperidine is same as that of pethidine. If someone asks you what is meperidine, so remember the answers that you know about pethidine, the same answers need to be given for meperidine. And 2-3 things about meperidine. It has got an active metabolite, normeperidine, and it gets accumulated, it is neurotoxic and absolutely contraindicated in MAO inhibitors. This is tramadol. You people have used it. It is a weak opioid and has got not only an opioid-like action, but it has also got non-opioid mediated action. The chances of respiratory depression are much lower with this drug. These are the various formulations, orally very easily available, also with other combination, paracetamol and all. And this is also used for giving, used in for postoperative shivering. Please do not use in patients who have got propensity for seizures or who have history of seizures. So neurosurgery patients postoperatively, it should be avoided. Buprenorphine, if you have used it, it's very effective, and you get patches also of this drug, right? And generally it is not as, because it's got a very long duration of action. It lasts up to 12 hours or so. That's why people are not using it. 1 ml contains 0.3 mg of buprenorphine. Remember that fentanyl has got various types of preparations. It is also used as a pre-medicant, as intranasal, also as lozenges, also, and then intradermal route also. You get patches, which is used for acute and chronic pain. Your naloxone is a drug of choice for opioid poisoning. And it is used, remember that naloxone is given as an IV preparation. It is not given as an oral preparation. And it completely reverses the respiratory depression. It is given in the doses that have been mentioned. But the duration lasts only for half an hour. So if you expect that the respiratory depression is going to be there for a longer period of time, it's a long-acting respiratory drug which is causing depression, then please give infusions. Other than that, there is another drug which can be given orally. It is naltrexone. This is oral preparation which is available. This is given in patients of opioid dependence, right? It is administered orally, and it is can be given in patients of opioid dependence. So these are some of the questions, and I have also given you the answers. This more or less completely covers up. Rest of the details, please read in the book, and it's a simple way of remembering this topic. Thank you. And now I hand over to the next for the next session.
Thank you
Dr.
so much,
Namita.
ma'am, for such elaborate discussion. We'll move on to the next session. That is short case presentation. A 66-year female posted for left-sided total knee replacement. The external examiner is Dr. Bimla Sharma. I welcome you. She is an esteemed faculty in Sir Gangaram Hospital, New Delhi. Madam is senior consultant over there. Her area of interest are pain, acute and chronic pain, and new airway devices. The moderator for the case is our senior resident, Dr. Sakshi Tikku, and the presenter will be a third-year postgraduate student, Dr. Rashim. Over to you, ma'am. Over to you, ma'am. Over to you, Bimla ma'am. Can you listen? Can you listen to me? We'll just wait for a minute. I'll just coordinate with ma'am. Good afternoon, ma'am. Ma'am, kindly unmute your mic. Yes, ma'am. Now you are unmuted.
Hear me now?
We can't hear you, ma'am.
We are already unmuted. I'm already unmuted. Rashid, you can't hear me?
Yes, ma'am. Now we can hear you.
Yeah, now we can hear, ma'am.
Hello?
Yes, ma'am. Now we can hear.
Over to you, ma'am.
The voice is, I can't hear you well. Is my voice clear? Rashid?
Ma'am, breaking, ma'am. Voice is breaking, ma'am. Your voice is breaking, ma'am.
Voice is breaking. It's so bad. Hello? Listen. Maybe I'll try with my phone. I can hold it like that. Okay. Okay. Thank you.
We'll just take a short break of 1 minute and then rejoin.
Recording in progress.
Hello? Can you hear me?
Yes, ma'am.
Hear me now? Hello? Dr. Nila? Okay, thank you. हमने तो अभी दोबारा ब्रेक किया दुकान हेलो नमिता ब्रेक ठीक है मुझे आवाज अभी तो देख नहीं रहता किसी को हो जाए ये वाला मेरे पास किसी के पास अभी नहीं है ये मेरी आवाज जा नहीं रही थी प्रकाश ये मेरे इसका कंप्यूटर है ना इसको
हेलो साउंड आ रहा है?
हेलो
हेलो साउंड आ रहा है?
हाँ हाँ वी कैन हियर हाँ आ रही है आ रही है
वीडियो में भी राइट दे दीजिए, वीडियो ऑन हो रहा है यहाँ से।
more stable, more prolonged duration of action, metabolize liver effects. Ester unstable energy and metabolize the
हेलो
वो आवाज नहीं आ रही मेरे वीडियो ऑन कर लीजिए
हेलो
वीडियो ऑन कर दीजिए because the people has stopped my video. Hello. I couldn't start my video.
Ma'am, it has to be turned on from your. Now it's there. Now it's there. Yeah, we can see you, ma'am, and.
Can you hear me now?
We can hear you.
Yes, ma'am. Yes, ma'am.
Hello, good evening.
Good evening, ma'am.
Good evening, ma'am.
Hello.
Good evening, ma'am. Good evening, ma'am.
Hello. Ma'am, we lost your connection.
Dr. Ashim?
Yes, ma'am.
Dr. Ashim, can you
Yes,
hear
ma'am.
me?
Yes, ma'am. Good evening, ma'am.
Is the voice okay now? Okay.
Yes, ma'am.
Then we start.
Yes, ma'am.
Okay. Good evening, everybody. I'm sorry for the delay. So, Dr. Rashid,
Ma'am.
you can start your presentation.
Yes, ma'am.